Good morning, everyone, and thank you very much for joining us here in the Rhythm Theater. And today we're going to be talking about electrocardiographic flow mapping using the Cortex system. And, I'll just sort of make a quick editorial statement right off the bat. These days with pulse field ablation, we're seeing people sort of do massive lesion sets which are not necessarily guided by any particular evidence. And I think that just because we have a new energy source doesn't mean that we don't have to map or we don't need to understand the mechanisms behind the arrhythmia. And so I hope we certainly don't lose our appreciation for that. So let me just do a quick introduction on the I'm not sure that this works, but I can use the computer. Can you help me out with the slides? So anyway, okay, all right, no problem. So first, we're going to start off with a polling question. So if you take your phones and you scan the QR code, you'll be able to respond to the polling question. So I'll go back and let you take a picture of the QR code. Give you 2 seconds to do that. All right, so the polling question is, considering the advancements in PFA technology that make it easier to perform PVI and posterior wall isolation in every patient, do you think personalized AF mapping is still relevant for tailored ablation strategies based on individual AF pathophysiology? So this was a super leading question given my editorial just earlier, but answer honestly. Okay, so I will go to the live polling here. Four seconds, and then, all right, so everyone picked the correct answer. But no, it's good that we had honest answers here. And there are some people who think, no, we don't need this in the realm of PFA. So, this is going back now into what I think is ancient history, but STAR-AF2 obviously was a trial that at the time kind of turned the field on its head. It said that perhaps PVI was just as good as isolation plus cafe electrograms or isolation plus linear ablation. Now, a lot of people took this to say, well, you know what, PVI is good enough for everybody in all cases. But remember, this was a trial that was comparing 2 other specific strategies. We didn't compare, for example, a mapping strategy in atrial fibrillation. And so since that time, there have been there's actually been a huge proliferation in technologies that are attempting to understand the pathophysiology of atrial fibrillation and trying to map atrial fibrillation. And this is one of those systems, which is electrographic flow mapping using the Cortex system. And what exactly is this? Well, it's using a 1-minute unipolar electrogram recording from a basket catheter that has 64 electrodes that enables panoramic mapping of the entire atrium. And you can map both the left atrium and the right atrium, and you're going to be hearing some data later on about how important the right atrium is in the pathophysiology. And then the OptiMap system actually shows you very visually and with accurate localization where the sources are for atrial fibrillation and how they're interplaying with one another. So these are all the details of the actual system itself. and how you can also pin out to the map nav system. So when you want to start projecting, whatever you're finding on the OptiMap onto your final map and actually ablating those targets, there is some way to be able to interact between the two. So here you see all three of the major mapping systems and how you can visualize the basket catheter and also put points or labels wherever those particular sources are located. Now, what exactly is EGF mapping? Well, the first thing that it's not is it's not a black box. So if you actually want to understand how this works, you can look at the late but the great David Haynes article that he published last year in JICE. And just as a quick word, David was a great human being, and he's sorely being missed in the EP community. So here what we see in the first screen are the unipolar intracardiac electrograms, and you can see then that the system then transforms these into optical intensity type signals. So basically it takes the unipolar electrogram, assumes sort of like a power to each of those electrograms, and then visually displays them like that kind of map that you see on the second frame, which almost looks like a topographic map of any land or anything like that. Then basically those optical signals are then transformed into a dynamic visual map, and that's what you're seeing with the arrows. So you can basically trace the flow, if you will, coming or emerging from the sources. And these are just dynamic images to show you that point. So that yellow point that is displayed on the last is representing a source, and you can see how all of the waves are emanating out of that source and indicating that it's real. So EGF mapping is really like adding on to PVI. There may be some patients where PVI may be enough, but in other patients, clearly, whether they be redo patients where PVI's already failed, persistent patients where PVI may not be enough, or even some paroxysmal patients who may be more complex than your usual patient, you can see with this mapping system sources that you can then target and ablate that are outside of what you would usually cover with your PVI. Now, in addition to being able to improve outcomes, and I'll show you some of this data in a moment, we can get a sense for the phenotype of a patient based on whether they have active sources or no sources. So for example, if you have patients who have no sources and you decide to do just a typical PVI or minimalist lesion set, those patients may actually end up doing well no matter what you do. But as soon as you start having active sources, that's a more complex form of atrial fibrillation where those patients are not going to do well with just a minimalist approach, and you need to address those sources in order to improve those outcomes. So sometimes when we see really disappointing outcomes in persistent AF, it may be because we're not properly phenotyping the patients and not properly addressing that phenotype. Now, FlowAF was a multi-center randomized controlled trial which actually took patients from 4 centers in Europe looking at acute procedural success as well as freedom from adverse events, but as part of the secondary endpoints, they were also looking at long-term AF recurrence. And the idea here was to see if EGF mapping in redo patients with non-paroxysmal atrial fibrillation could improve outcomes. Well, first of all, there was reliable identification of sources demonstrated by this trial. Vivek also showed in this trial that if you map sources and then you remap a few minutes later or even at the time of redo procedure, if you didn't address an original source several months later, that these sources are spatially and temporally stable. So in other words, it's not like you'll do one map, see sources in one location, do another one 20 minutes later, and suddenly the sources are in a totally different place. These are spatially and temporally stable sources. So in this trial, 95% of patients randomized to EGF-guided treatment arm had a confirmation of at least one source ablation on and one source identification and elimination on post-ablation EGF mapping, and the safety for this system was very, very good. So if we look at the outcomes here, we see that the patients who received, these are patients in whom sources were identified. And half of the patients were randomized to say, you see the sources, don't do anything about them. Just do a PVI, re-isolate the veins, that's it. Don't touch the sources. In the other group, which is the PVI plus EGF guided ablation, you saw the sources and you actually eliminated them. And you can see the huge difference in outcome, and particularly for the blue curve, if they had sources and you decided to ignore them, those patients did very, very poorly. So there are a number of trials that have been completed using this system, and you can refer to them. So there's already a lot of data, RCT and registry, to support the use of the system. There have been a number of publications, and I guess take a picture of this slide and zoom in on it, because I don't expect you to read all of these right now. But the most important thing is science is still being done. There was a larger US study which is being led by these people right here sitting beside me, called Resolve AF, where they're basically actively enrolling again in redo patients, seeing whether source ablation improves outcome. And this is the study design. One of the PIs, Kent Nilsson, is sitting right beside me, and it's all comers for redo ablation or de novos for persistent or long-standing persistent AF.
Thanks, Atul. All right, so next we're going to do 3 case studies. Each case is different and has different aspects that we'll present. The first speaker will be Kent Nilsson, who, as you saw, is one of our co-PIs for the Resolve AF clinical trial. And then Ilana Kutinsky, who is also one of our principal investigators for the trial, and Wilber, also a principal investigator for the trial. And so each of them will present a case next.
Okay, so I want to present the case. This is kind of one of those like aha moments where I really started getting super excited about the technology. So by introduction, I'm Kent Nilsson. I'm one of the electrophysiologists in the Piedmont Heart Institute's system in Athens, Georgia. So as Melissa mentioned, we're going to do a couple polling questions, and I'd like to, if you guys can scan the QR code, give you guys like 5 seconds, and then I'm going to go on to the first question. So for de novo persistent and long-standing persistent AF patients, what do you do in addition to PVI? Do you stick with PVI only? And if not, let's see, do you isolate the posterior wall? Do you do a roof line? Do you go after cafes? You try to do GP mapping and ablation? You try to isolate the left atrial appendage? There's a lot of things there, so I'm going to hold here for a couple seconds, because once I hit the next button, then it's like you're on the clock. So, and then you have to remember what what E and I are. Okay, we good? All right. So live connect. Oh, okay. There we go. Okay. All right, this is okay. This is awesome. Okay, this is really good. So about a third of people just stick with PVI only, in keeping with the STAR AF data. Some people add a roof line. About a third of people add a roof line, and then other people do substrate modification. Right, cool. All right, for redo AF ablations, the main reason I perform empiric adjunctive ablations in addition to PVI is the guidelines support use of adjunctive ablation. There is solid evidence of incremental benefit to adjunctive ablations beyond PVI. And when the when the PVs are already isolated, I don't know what else to do. What? This is like leading into my next. Oh, and I can bill add-on codes, which different. Hopefully, no one is going to click on that, but yeah. So, all right. I have one more. All right. Yeah, okay, good. This is a great lead-in. All right, so this is a patient I had, 64 years old, paroxysmal atrial fibrillation, comes in for a redo ablation for recurrent symptomatic AFib that we did back in 2021. Standard guy. He was actually relatively fit for being in Georgia, free-range Georgians. We kind of eat ad libitum. And so he, BMI is 40, past medical history, persistent AFib, had a decent sized left atrium, had a CTI line at the time of the original ablation. Those are the medications that he's on, anticoagulation, standard rate control, not on an antiarrhythmic drug. And all right, so we map them, and this is the case that we run into, right? All veins are essentially isolated when you get in there. His left atrium, as we normally quantify atrial substrate, he's got relatively high voltage throughout the atrium, right? 4 veins essentially isolated. What do you do in this situation? And I think this is, like we run into this all the time. And when I talk to all of my colleagues about this, they all know exactly what to do, and everyone has a different approach. So we touched him up, and we isolate. I kind of extended the WACA lines, kind of extended into the posterior wall a little bit more, and then he was enrolled in our clinical trial. And so let me talk about this a little bit. So after we kind of widened the WACA lines, we gave him adenosine per protocol, confirmed isolation. We used a 50 millimeter basket catheter, and then we burst paced him. And we put him into sustained atrial fibrillation with a not particularly aggressive protocol. And so he's in sustained AF. We put the basket in, and this is what we see, right, with the OptiMap system, which, I've been looking at these for a while. I was hoping, like, initially when we went to high definition mapping, that I would eventually start to be able to see the matrix. I still have not been able to see the matrix. As Atul went over, like, there's a series of mathematical algorithms that are performed that identify that analyze and look for these sources. And I think one of the things that's really key about this technology, which is different than the approach that we have traditionally taken with arrhythmia, with EnSite, and with Cardo, is that when you make a map of patients in a persistent atrial fibrillation, you're using a stamp and stitch model where you acquire an area, and then it's put next to another area, and it's put next to another area, and that creates a 3D anatomical model for you. This entire technology is addressing the fact that these rotors are temporally and spatially unstable. You can have multiple of them, and they can switch between different ones. And so in this layout, what the analysis is done is over 30 2-second segments over a 60-second interval. So you do a recording for 60 seconds, and then it splits it out into 2-second intervals, and then it identifies the source that is the most dominant and active. So looking at, this is kind of the way, this is what's presented to you. It's a heat map that goes up on our flat screen TV that's also playing a Georgia football game on the side. But the just kidding. So on the left is the summary. So that's an aggregate of all 60 seconds showing the most dominant source. On the bottom is a series, is what you're seeing is 2-second segments over 30 2-second segments. And on the right, what you're seeing is a visualization of the source activity and also the electrographic flow. And the electrographic flow consistency is something that we're also seeing as a very, very good marker of atrial myopathy. And there's some data on this that it's very predictive of who is going to recur with persistent AF, irrespective of whether or not people have sources or don't have sources. So this is what you see. All right, so this is, so I get the data and they call out like F2 or wherever it is. And so I have my mapper lighted up on the map, and it's coming kind of from the base of like the intersection between the left atrial appendage and the left superior pulmonary vein. And, you know, going into the appendage is not something that I traditionally do. So I kind of started with a more conservative, started on the roof and kind of worked my way in. And eventually I was like, okay, well, you know, I would map, remap, ablate, map, remap, ablate. I'm like, okay, this is coming from inside the left atrial appendage. So I got inside of it. It was on the roof towards the ligament of Marshall, and I ablated that area. And when we went to remap, he terminated while we were remapping. So this is about 15 seconds after we started remapping. I'd come off ablation, said, okay, let's see where it is again. And now he terminates, and he is inducible, but no longer sustains for more than 15 seconds. So we are no longer able to actually sustain his atrial fibrillation. I was going through this. The overall time that we spent actually doing mapping and ablation of the source activity was only about 5 minutes, which is, you know, like what would I have done if he wasn't part of this clinical trial? I would have, I don't know, I would have gone after low voltage areas. I would have, like, you know, blown up his, done a roof line, maybe tried to isolate his posterior wall, whatever that does. And anyway, so that led to him to being no longer to be able to sustain atrial fibrillation. This is one of the early trials that looked at a combined approach of either doing PVI only, PVI plus lines, and PVI plus EGF guided ablation. And there was a pretty dramatic increase in success or decrease in recurrence of atrial fibrillation compared with PVI alone if you use EGF source guided ablation techniques. This was also a slide from the original paper, which we've also reconfirmed in FlowAF and what we're actually kind of seeing anecdotally. And this is looking at where the sources are coming from. So when in the CRF, you have to identify where the sources are coming from, and they plotted this out. So if you do everything that we would think about doing for PVI in a persistent AF, you isolate the posterior wall, you do a roof line, you do a mitral isthmus line, you do a second mitral isthmus line, you take out the anterior wall, you isolate the SVC, you're only hitting 60% of the sources that were identified in these trials. If you just focused on the posterior wall, say you like do a roof line and you hit the posterior wall, that's 11 to 12% of the sources, right? So like half this, yeah, so just emphasizing that there are sources on the posterior wall, but they're not the dominant sources in persistent atrial fibrillation. So this is a summary slide of all of the trials that have been done looking at things at adjunctive therapy for beyond PVI for persistent atrial fibrillation, and pretty much there's no benefit, there's no proven benefit, and as a result, none of the guidelines support doing anything outside of that for persistent atrial fibrillation. Yet collectively, our field has decided that there are things that need to be done for which there is no data to support the benefit of that. As Atul mentioned, this is the FlowAF randomized clinical trial. It's been accepted. It was presented last year here at HRS, and it showed if you use EGF guided source ablations, and this is a difficult to treat, redo persistent population, randomized clinical trial, 4 different centers. There was a 51% absolute increase in freedom from AF if you use EGF guided source EGF guided ablation in addition to PVI. So in conclusion, so EGF in this situation identified extrapulmonary sources that were able to actually stabilize, that were actually able to maintain atrial fibrillation in a persistent atrial fibrillation patient. When PVs are isolated and AF recurs, EGF mapping can identify both extra PVI pulmonary variant sources and drivers that maintain persistent atrial fibrillation. Tailoring ablation sets to an individual patient may be more advantageous than just nuking the entire posterior wall and blasting away. Currently, we are enrolling in the Resolve AF trial. It's at 37 sites across Europe and the United States. We're about a third of the way through it, up to 500 patients, and hopefully this will definitively address the role of EGF mapping in the future. And with that, I'll turn it over to Ilana.
Hi, everyone. I'm Ilana Kutinsky. I'm at Beaumont in Detroit, and I'm going to go pretty fast. Good thing I can talk fast, because we're running out of time. No, it's not you. And we want to hear Wilber's case also. So, okay, so I have very similar experiences to Kent, and so if you haven't scanned, please scan. Here's the question for your persistent, long-standing, persistent AF patients. How often do you ablate in the right atrium, not including doing a empiric CTI line or a CTI line? Okay, you get 15 seconds. And I think that participating in this trial has shown me, at least, that the value of doing sources, and I don't want to do redos without it. So never, rarely, occasionally, sometimes. And it's good nobody did frequently or always. So let's take a look. This is my case, 62-year-old female with persistent atrial fibrillation who presents for a redo catheter ablation of her symptomatic recurrent atrial fibrillation. She's a normal Michigan woman. She is obese, and she was in atrial fibrillation on arrival to the lab. Her first case was a cryo case. It was done probably about 4 months prior, and she had failed flecainide before. We had put her back on flecainide. The flecainide failed again. When we did the case, she had been off of flecainide for 10 days. A lot of times we would go in, and this isn't uncommon, you see a little bit of connection there between the right middle and the right inferior. We touched up our pulmonary veins. We did a little on the anterior LSPV as well. And then we confirmed everything with adenosine, and then we re-induced atrial fibrillation. So part of the trial, you have to have atrial fibrillation that sustains for over 60 seconds before we go in to put the basket in and remap. I use Cardo, and so this is catheter visualization of the basket inside our left atrium. And you can see we had one active source in the left atrial posterior wall. And I do a very similar thing. I ask my mapper to kind of like highlight a circular area between G2 and H2, and I ablate in that area. This is our ablation area. This source sort of moved a little bit, so we ablated in that area, and then we retested. We redid another 60-second basket, and it was just above where I had ablated, so then we extended and completed the lesion set. Then we re-induce, and at that site, I think that there is no longer an active source at that site. So you can see on the left, there's no big kind of target, orange target. And so then we went to the right as part of the protocol. We do several baskets in the 2 basket sites in the left and then go over to the right. We did the right, and we see a very active source. Its activity is over 60%, and this is consistent on multiple checks. And we burned that source, and as we're burning that source, it organized and then terminated. This is not the first time I have had this happen with right atrial sources. So in this patient, the patient had sources on the right side and on the left side. And in my mind, at least, I don't routinely go to the right side in patients in my redo cases. I hadn't been. And so this has really sort of opened my eyes. The mapping time in the left atrium with the basket was 8 minutes. In the right atrium, it was 1 minute. And added ablation time with EGF was a little over 5 minutes. So the total time for mapping and ablation was 14.5 minutes, which is, I think, a reasonable amount of time. This is some work done from the flow study that is going to be published, and it shows that about almost 50% of sources come from the right atrium. And so I think that another reason that if you do your posterior box and your roof line, you're really missing out on a lot of sources in these patients. Again, you've seen this data previously with, I think Atul presented one of these slides, but I think it's interesting to say that you're not only being free of atrial fibrillation, you're also avoiding atrial tachycardias and atrial flutters by not adding lines that are unnecessary. And so I think this is really important data. So in conclusion, the EGF identified extra PV sources of atrial fibrillation were equally distributed between the right and left atriums, and there were a mean source of 1.3 sources per patient. Focused minimal ablation strategy tailored to your atrial fibrillation pathophysiology, again, looking at that phenotyping that we talked about, looking at the healthy tissue plus sources, may optimize the freedom of AFib without trading atrial fibrillation for organized arrhythmias like atrial tachycardia and atrial flutter that you're going to take hours chasing down. Again, we're enrolling Resolve AF clinical trial in patients right now, and we're going to examine whether EGF-based treatment improves freedom of atrial fibrillation and atrial flutter or flubber in a broader AFib across the nation. I'm going to give it to Wilber.
Thank you. I think it's always, I'm Wilber Sue. I'm director of EP at Banner Health and U of A. I think it's funny, as I was walking in and bumped into some of my colleagues, and the first thing they say is, "Aren't you the cryo balloon guy?" It's like, yeah, but that's 20 years ago, and guess what? 80-90% of the AFib we get are all these redos now, right? So this is why this is so critical to our practice. I'll try to speed along. Now, with another polling question, make sure you participate in the fun. So for redos, when you get these complex fib flutters, it's a challenge because it cannot be mapped, right? So how often do you see that? Is it less than half, about half, more than half, or most of the cases? Move on to these. Go ahead. Yeah, let's take a quick poll there. We see this all the time, personally, and the question is, it's always, when Cortex approached me to say, hey, this is what we're doing, and what do you think we're missing? And essentially, what I said was, this is how I would think about doing it to map the unmappable, and they already did it, right? So yeah, you see it quite often. So I'll show you a case that's pretty typical of what we see. So this is a 72-year-old fib since about 10 years ago, and by atrial enlargement, the typical failed drugs, cardioversions, eventually had an ablation in 2016. Off drugs, did fine, progression of disease, came back, got drugs, and went back and actually this is done somewhere else that they said, okay, well, let's just get the lines done, right? That's the next approach. They got some lines done, CTI, roof lines, and put back on drugs, and of course, recurs. So patient arrived, patient's in sinus rhythm, And first thing we do, check previous work, right? So CTI is done. We went across, and we said, all right, I like to define the substrate. So I like arrhythmia. I like to have the high density map to say what the substrate looks like. So this is what I get. And as I'm mapping, I'm pacing, and say, hey, where are you not taking points? Well, a patient went into TAC. Well, map the TAC. Well, we can't map the TAC. Why can't you map the TAC? Because it's variable. Well, just try. So we keep on trying, the patient keep on going. This is the map we got. So you notice it's regular enough here and there, but it degenerates. It goes back and forth, and this is exactly what I'm talking about all the time, right? You see this all the time. And how do you map this, right? Because it looks regular enough here and there, but this is what it does, right? And it's all over the place. So it goes fib, flutter, back, forth. You know, this is flutter 1, that's flutter 2, that's flutter 3. Add to this, do that. You know, this is what we get. So we cardiovert, we map the substrate. We say, all right, let's check where the voltages are. Let's make sure the lines are done first, right? Maybe that's the problem. So this is a typical struggle, right? A lot of people nod your head, right? So you continue to get in and out of this, and 3 cardioversions later, we continue to finally get the map. So the map shows this, okay? We have PVI that I did before. We have lines that was done, and the lines shows that the inferior posterior wall. Typically, I get more of a vestibular portion, so I didn't do this, right? If you want to find the esophagus, that's how you do it. So there's probably a gap there. And you know, what's interesting is also the roof. It's not a typical seatbelt line, but okay, they did a roof line. There's a gap across the line. The report said that they went for RSPV to LSPV, so that wasn't done. So, you know, I got bombarded with this. A lot of the white area, typically my line is a straight line, but there's a lot of fractionated stuff there. I have the white in there. You have to kill everything that actually twitches. It's half dead. So that's kind of the line I did to try to complete that line. So after it's completed, then we said, all right, let's see if we have anything else, right? Yeah, of course, you get induced the same thing, right? So, you know, as we do this, then we say, okay, is it still mappable now? Now the roof line is done, the anterior line is done, theoretically the posterior line is done. What do you have left, right? This is kind of the lines you have, right? So you know you're not dealing with the macroentrant flutter if your lines are truly done. So of course then this becomes a fib and say, okay, great, let's get this system in and see what it can tell us. So a basket goes in, you try to see what's going on, and it generates a pretty map. Honestly, in the case, I don't get to see this map and study it, right? I just kind of look at it and say, all right, tell me the coordinates. And occasionally I'll sneak around the screen, look at it, and say, hey, that's pretty. I say, just tell me where to ablate. Right? So you can see that highlights a nice source there. So the source is in this area, behind where we originally had the original line. Now this is interesting here as well, because as I was mapping all the time, in this case, there were few initiations where I'm in the posterior wall, and I know my local electrogram is earlier than most of the triggers in the duodeck that I had in there. So I said to myself, I would be impressed if my first map actually shows me something near here, as if it actually worked, right? So it did. It actually showed this area. And so we said, all right, we ablate that area, and it shows that the source is gone. And then we come back to the right atria, and of course we also then continue to induce a fib at that time to say, well, maybe that was the only source that's needed. So we moved to the right atria, we got it to the right atrial position, and we induced fib again. So this shows another source in the right atria. It's like, well, of course, like most of you, as you saw that, it's not typical that we find the right atrial source. In fact, right atria looked pretty healthy to me. So this is not something I would have gone after. But this was something kind of high septal posterior, and we ablated that. So, of course, as we actually ablated it, and soon after, the thing terminates. So this is a case where a fib flutter started, initiated back and forth, and it just never stopped. And just like her clinical presentation. And I'll say this is probably one of the first ones that we say, gosh, maybe really looking at something that works, that can map the unmappables, right? Because I can tell you arrhythmia, if you're looking for regular, something that maps one section at a time, right? You can't map these, right? So of course, then it's non-inducible afterwards. And this is kind of summary of the lesion sets, all right? So we have the source in the posterior side, below that previous line. The temptation was complete that inferior line, but actually we didn't need to, right? So then we also have the roof line that was completed. And so most of the time really was spent in completing the previously uncompleted lines. But even with that, we had two sources that was clearly driving and initiating AFib that would have otherwise yielded to a failed procedure, right? So in summary, basically, it was essentially one right atrial source, one left atrial source. The total time is only 7 minutes in mapping in the left atria, 1 minute in the right atria, and really we ablated for just as long as we mapped for, right? So it really yielded to a total of no longer than 15 minutes in the case. The typical redo for us is a whole morning, right, to try to figure out everything. So I think you look at the ability to really truly map the entire chamber to see where these are deriving from is where mapping has not been before, right? And this is truly untouched territory. And for us, we've been always looking for these type of solution, right? Having come from Topera, Cardio Insight, to see why it really doesn't work. This is actually one that has been pretty consistent, that's showing that these are all the things that yield a fairly nice outcome. And I won't iterate some of these things that you can only gone so far with the typical lesion lines. And I think it's classic for the case we just showed you, right? And it really doesn't improve outcomes when you start doing empiric things. So in conclusion, the EGF map certainly is able to map the unmappables, right? The things that shifts, is able to bend them appropriately according to time, and give you the highest yield mapping that shows you where the source are coming from. So I think in this case, you can clearly see that lines, completing them, certainly should be a part of the procedure, but that's truly not the problem in this type of patients. And this is what we see now all the time. And of course, for these complex AFib, beyond PVI lines, this actually fits very nicely into our practice. Thank you.